Hi, my name is Javed Syed. I'm a vitreoretinal surgeon. Here is a case of me repairing a retinal detachment with the Plana Vitrectomy. The retinal detachment is identified. It's a bullous detachment. The macula was already detached, and a break can be seen superiorly. The vitrectomy handpiece is introduced into the eye and used to perform a core vitrectomy. We can see a shallow indentation peripherally from a scleral buckle. I tend to put a buckle on a lot of my cases of retinal detachment. There's good evidence to show that it increases the single operation success rate of a retinal detachment repair, which is really critical to having good visual acuity results. Here, I was doing a peripheral vitrectomy, and my cutter came over the peripheral break, and we can see that during my peripheral vitrectomy, the fluid is draining out from the break, and the retina is flattening nicely, which makes it a little bit easier to complete the peripheral vitrectomy as the bullous retina is now relatively flat. So here I'm using the vitrectomy handpiece to remove the flap of the tear. This helps to reduce the residual traction on the retina and reduce the chance of redetachment. There was a little bit of oozing from a bridging vessel, and it is quickly cauterized with the endodiathermy. The endodiathermy is also used to mark the break so it can be better visualized after our fluid hair exchange. After completion of the peripheral vitrectomy, a shave vitrectomy is then done. An object or a scleral depressor is used to indent the peripheral retina and vitreous so that it can be visualized and removed with the vitrectomy handpiece. A complete peripheral vitreous removal helps to increase the success rate of these surgeries. I'm doing the same, removing any residual traction over our retinal break. I then switch hands and complete the shave vitrectomy on the other side of the eye. This is a phakic patient. That's why I'm not crossing the midline. Next, the soft tip cannula is introduced into the eye and a fluid air exchange is performed. I'm draining the residual subretinal fluid through the retinal break. Although many cases I will form a draining retinotomy using the endodiathermy, it was not necessary as this break was readily accessible and most of the subretinal fluid could be drained nicely from this opening. There is a little bit of concern when draining through the break that residual posterior fluid can result in a macular fold. In these cases, to reduce the risk of that, I actually leave the patient in supine positioning for a couple of hours, and this is thought to reduce the risk of macular fold formation and has worked great to date. Here I'm using the endolaser to place some laser around our retinal break. This helps to spot weld the retina in place so that once our air or gas bubble has resolved, the retina will not come redetached. I am placing some light peripheral laser 360 degrees on the buckle, again to reduce our rate of retinal redetachment after surgery. The soft tip cannula is reintroduced into the eye and used to remove any residual fluid, which is minimal. In this case, a air-gas exchange with 24% SF6 gas was then done through the infusion line while venting through one of the cannulas. This patient did quite well post-operatively with corrected vision going from hand motions to 20/30 about 3 weeks after surgery despite the macula off status. Again, this is Javed Syed presenting a case of a retinal detachment repair. Thanks so much for watching.